Welcome back to week 5. We are talking about high-risk pregnancies. We're going to huh? You good?
Yeah.
We're talking about bleeding issues in pregnancy, okay? Kind of broke it down in that way, as well as infections. So depending on where the woman is in her pregnancy, there's different sources of bleeding. In the first trimester, bleeding tends to be miscarriages or threatened miscarriages. Ectopic pregnancies. The health of the pregnancy and the outcome of the pregnancy is certainly in question. In the second trimester, if she's bleeding in the second trimester, most likely it is gestational trophoblastic disease or a molar pregnancy. In the third trimester, bleeding tends to be a problem with the placenta. Okay. Spontaneous abortions. Well, spontaneous abortion is the unfortunate ending of a pregnancy within the, what was it we decided? First 20 weeks. After that, it becomes a preterm delivery of a baby who did not survive. So it's the 20-week mark, or a baby less than 500 grams. So we have a couple of different kinds of spontaneous abortions. We have a threatened spontaneous abortion. Threatened means it's not looking too good, but it could go either way. You know, there was some bleeding, but the cervix isn't open. Maybe a little cramping. I've seen threatened abortions resolve and the pregnancy continues. So it's still kind of on the fence of so what's happening. All right. Then you have inevitable. Now we're talking the cervix is starting to open a little bit. Mild to severe bleeding and mild to severe cramps. This is, the writing's on the wall, but it just hasn't happened yet. All right. An incomplete abortion is when, yes, the cervix open, yes, there's a lot of bleeding, lots of cramping. That uterus is working really, really hard to rid itself of this pregnancy, but it's just not doing it completely. So that's why it continues to bleed, it continues to cramp, and it ends up, can cause quite a bit of a problem for the mother. In terms of blood loss and whatnot. So she will oftentimes be taken to the OR for a D&C to finish it off so that she's no longer being tortured. And then a complete abortion is when all of the contents of the uterus, the products of conception, we call it, come out and then it's over. Sometimes this is where a woman will feel something and like while she's going to the bathroom and she sees this bloody looking mass, like a little clump of stuff in the toilet, and that was her entire pregnancy. Yeah. After this happens, there's very little bleeding. There's no cramping because the uterus ended it and there's nothing else for the uterus to do. I want people to know the difference of these things, but more importantly, remember it's a loss of a pregnancy. Plain and simple. Oh, you were only 6 weeks. That was, I thought I was bringing a baby into this world. I loved that baby already. So it's a loss of a baby. All right? It doesn't matter. It doesn't matter how many weeks. It doesn't matter if she can try again. It doesn't matter. None of that matters. It's a pregnancy loss. Whether it's 40 weeks along, whether it's the child at 2 years old, whether it's a 6-week pregnancy. It's a loss of a pregnancy. Just be sensitive to that. And I'm sure for those who have experienced it themselves, they can appreciate my thoughts on that. This missed, it's kind of like the incomplete. There are no, no, this isn't. It's alike in that we'll need to go and intervene somehow to resolve it, all right? Missed abortion is, there's no clue. There's no cramping, there's no bleeding. The woman probably just goes in for her prenatal visit, and they can't find the heartbeat, or they go in for the ultrasound, early ultrasound or whatever, and there is no heartbeat. So the baby just dies in utero, and they discover it when they go looking, figuring it out. So they have, depending on how far along they are, will depend on how, what intervention is needed, whether it's a D&C, which is dilation and curettage, whether it's a dilation and evacuation, which uses suction, or an induction. Later in the first half of the pregnancy, the safest way is to actually induce the woman. So 18, 19 weeks along, they will bring the patient most likely to the labor and delivery unit, and she will deliver her baby. A septic abortion could be any one of these things, but the mom gets pretty gosh darn sick. What came first, we're not sure. Was the uterus and the products within infected, and that's what caused the demise? Or did the products and uterus become infected after the baby died and just created a source of infection? I don't know. Nonetheless, mom's pretty sick, so we will have to intervene at a minimum with antibiotics. But sepsis is sepsis, no matter what the source. So.
Could the open cervix have caused the infection?
Yeah, well, yeah, definitely. I mean, the open cervix, maybe, if she was a little further along within the first half of the pregnancy, maybe she broke her water, and just any ascending infection, whatever it definitely could be part of the issue. But mom is plain old sick. Yeah, feeling pretty lousy. The poor woman who has a recurrent spontaneous abortion. Just means she's been down this road one too many times. All right. I'm sure for anyone who has had a miscarriage, the next pregnancy is all that more stressful. And until you get to the magic number along the way that you were the last time, when you had the miscarriage, you were waiting to get past that point before you let out your breath. There are some who go through it time and time again with no success. Sometimes along the way too, but multiple miscarriages, which is just multiplies the heartache. These are your pictures of all those different kinds that I talked about. Why? I don't know how many times I've had patients tearily ask me, why? Well, I don't know. Gosh, if I knew, I don't know if it would help or not. Is it an anomaly that just wasn't compatible with life? Was there something wrong or not ideal with the uterus? I don't know why. Sometimes we know that there is a uterine abnormality that might make a successful pregnancy more difficult. Sometimes, especially with recurrent miscarriages, they might do some pathological testing on the products of conception to say, well, maybe there's some genetic thing we don't know about, that maybe both parents are carriers and they keep maybe a recessive genetic problem that is not evident in themselves, but when they get together and they end up having, creating a baby that has this genetic disorder, that's a problem. I don't know. But they might do some pathological and chromosomal testing and find out, get some answers to their questions. Of course, maternal illness, drug use of any sort, whether legal or illegal. Premature cervical dilation is another issue, which we'll talk a little bit more about. And trauma is a big one, whether inflicted purposely or accidentally. What are we going to do? Well, if there's a lot of bleeding, probably going to get a CBC to see just how much the woman has bled. Probably also get some coagulation factors too. All right. If we suspect infection, we're going to pay attention to white blood cell count. If we're in that threatened stage where we're not really sure how this is going, we might draw an HCG level. Human choreo. That's the hormone that we use to detect a pregnancy in the first place. So as a pregnancy, early in pregnancy, as it progresses, we would expect the HCG level to double within 48 hours of a normal, healthy pregnancy. So we got a little bit of bleeding, the cervix is closed, woman's cramping a little bit. Right now we see a heartbeat. I'm not really sure what's happening. We might draw an HCG level and ask the woman to come back at 48 hours later to get another HCG level. All right? So 48 hours later, we would expect that number, we get a qualitative or quantitative level. We would expect that level to double. If it does not double, or if it decreases, that's another piece of the puzzle. This is no longer a threatened abortion. It's an actual, all right? We know that the pregnancy is ending. We'll definitely do an ultrasound to confirm whether there's anything left behind or if, any intervention is necessary, as well as certainly an exam, probably a speculum exam to assess the cervix. So as I mentioned, D and C, or dilation and curettage, a D and E, we'll do a little bit later in the pregnancy, or we will induce with prostaglandins and oxytocin to deliver vaginally. Those are the patients that I usually take. I'll take them because I know that I can be there for them. Those are the ones that need me most. You know what I mean? Not me personally, but they need the support and somebody who's not afraid to face that with them. I will induce them with whatever medication is being ordered and drug them up as much as they want to be drugged up. We don't have to worry about the health of the baby, right? So I will give them an epidural. Not me personally, but I will advocate for them to have an epidural, morphine, whatever. I don't care if they sleep through the whole thing if that's what they want to do. This is a terrible, terrible thing that they have to go through for more heartache at the end. So it's working with the patient and the family on what it is that they want, offering options for them. Following the delivery is now, it's not a specimen, it's a baby, in my opinion, which is another reason why I should be in that room. How do you want to handle that? Do you want to see your baby? Do you want to hold your baby? No matter the condition of that baby, no matter the size of that baby, I'm going to dress that baby, I'm going to take pictures of that baby, and I'm going to get handprints and footprints as best I can so that they have something tangible to take home with them. whether they want it then or not. I tell them if they don't want it then, we will put it in an envelope. You can just take the envelope with you. If you don't even want that, we'll keep it on file for a couple of years. You call us. If you change your mind, it'll be here. Some go as far as to hold the baby and for a period of time, take their own pictures, that sort of thing. Some don't want to see the baby at all. Some want to see but not hold. It's a variety of things. We have to have the conversation, which is tough, and we just go through whatever it is that they want to do. No matter what they say, I dress them. I take pictures of them. I will swaddle them up in a tiny little blanket. I will do my best to get those tiny little hands and footprints, whether they say they want them or not. Because even a week later, a year later, they might realize that that's all they have of that life that maybe not even a lot of people even knew about yet. So, pretty tough business, but it's what we do, right? We support our patients through whatever life throws at us. So yeah, we're gonna drug them up as much as they want or as little as they want. We're gonna help them grieve. If it's below 20 weeks and they want a funeral, we do have to go through the funeral home for all of that. A little extra paperwork. If it's after 20 weeks, it's no longer a miscarriage. It's a preterm delivery with a non-living child. So it's a birth certificate and a death certificate with the same times on it. A little bit added information around documentation. So a lot of the rules still apply. We want to wait till you stop bleeding, give them signs and symptoms to call the doctor for, provide some information about support groups or people to reach out to if you're needing a little extra help in dealing with your loss, that sort of thing. We really want the body to completely heal and get back to a pre-pregnant state before attempting pregnancy again. Hormonally, the environment inside the uterus, however the pregnancy ended, we want an optimal environment for the next attempt. So it's really important to stress the wait for 2 months before trying again, which is a tough pill to swallow for some couples, I do know. But all right, ectopic pregnancy. Ectopic pregnancy is a pregnancy that is progressing along, but it's just not in the right gosh darn place. All right. Most people think when they think ectopic pregnancy, they think tubal pregnancy, right, in the fallopian tube. But it doesn't have to be in the fallopian tube. It could be in the ovary. I've heard of pregnancy that was implanted in the intestines. I don't know. It went out the wrong chute. I don't know. I don't know how that happened, but no, not what you're thinking, people. The ovary, I know what you're thinking, and it wasn't that. All right? Instead of coming down the fallopian tubes into the uterus, you go out, and it's not, the ovary is not 100% attached to the fallopian tube, and it shoots out, I guess, and implants on, I don't know. Those are harder to find. So, for all intents and purposes, you're pregnant. You're setting off the hormones. Your HCG levels are coming back healthy and normal. Maybe they find it when they go to do an ultrasound, and they can't find the pregnancy. They can't find the little baby in the uterus anywhere. So they go looking elsewhere, and they find it in another place. Tubal pregnancy. ovarian pregnancy, large intestine pregnancy, colon pregnancy, I guess we'll call that. Sometimes we find it when mom starts having symptoms. So about the 6th to 7th week, that embryo starts getting big enough to cause trouble. So if it's implanted in the tube is very small. 6 to 7 weeks is when it's growing big enough to start causing pain, possibly bleeding, possibly surgical emergency when the tube ruptures and there's internal bleeding. So you get a woman coming in, I'm pregnant, I'm having this unilateral stabbing pain, one-sided pain, maybe bleeding, maybe not, we don't know. But pregnant at the 6 to 7 week mark, one-sided pain, that's your key, all right? Or if we have a stabbing pain, they don't know if they're pregnant or not, get an HCG level. If they are pregnant, all right, now we can no longer assume appendicitis. It could probably and most likely be an ectopic pregnancy. Unilateral stabbing pain. Key. Yeah? Okay. So, God bless you. And we're going to do an ultrasound. And we're going to hopefully find where this pregnancy is. All right? Or where it's not. We might have to go searching a little bit more for where it actually is, but we're going to confirm that it's not in the uterus and go looking elsewhere. There's a couple of different ways we can go about it. If we've caught it in time, then we might be able to just go get it, take the little piece of the tube out that was affected and like reconnect the tube, all right? Might be able to do that. If it's farther along and it might be quite an emergency when it ruptures and the woman has internal bleeding to the point where she has right shoulder pain because the blood is collecting in her belly and pressing up on her diaphragm. When there's right shoulder pain included in all of that, it's probably now a surgical emergency. All right? This is where she'll lose her tube. It's beyond repair. She will lose the fallopian tube on that side. The ones that we find kind of, not by accident, but we find before it starts causing trouble, the early ones, we might be able to medically manage those. The woman, if her HCG levels are below a certain number, we might be able to give mom some methotrexate. Not some, it's very calculated based on her weight. And it's a chemotherapy drug, so she's getting an IV infusion in the hospital, ambulatory care, by a chemo-certified nurse. And it's a much larger dose than what some people get for a variety of reasons. And what that does is dissolves the pregnancy. There's labs to keep track of, not just HCG levels. We expect to see those gradually decrease over a period of a couple of weeks. I have seen some patients need a second dose of methotrexate, but it avoids surgery. It avoids a problem with losing their tube or scarring their abdomen. There's your pictures. All right, that second trimester is the most likely source of bleeding is molar pregnancy or gestational trophoblastic disease. What this is it's pretty tragic actually. So at some point early in the pregnancy, something went awry. All that dividing and multiplying of the cells, it just went haywire, all right? And it has caused this cancer-like growth inside the uterus. and it is, it can actually invade into the uterine wall and like rupture the uterus, get like eats away at the uterine wall. Sometimes what we might see is a patient comes in, if we haven't done any diagnostic ultrasound or anything early in pregnancy, and her HCG levels might be extremely high compared to what we would expect at this stage of a pregnancy. Her uterus is much larger than when we would expect at this stage of the, whatever stage she's in. Maybe she's having extreme nausea and vomiting, which might be associated with elevated HCG levels and elevated blood pressure long before we would expect pregnancy-induced troubles. Okay? These are all clues that there might be trouble. So what we're going to do is an ultrasound. An ultrasound is the only way to truly confirm molar pregnancy. There are different kinds of, there's two in particular. There's a complete mole or an incomplete or a partial mole. All right, the complete mole, there's absolutely no genetic material in the fertilized egg. All right, there's no placenta, but the hormones are there, sending signals to the body, but there's nothing there to receive it. That's where you're going to get some excessive bleeding too, okay? No fetus, no amnion, nothing. All right, 20% of these complete molar pregnancies progress to choriocarcinoma. Wow. A, you're not having a baby like you thought you were. B, you have a 20% chance of having cancer. Slap, slap, right? That's why I call this the tragic second trimester trouble, all right? Yeah, that's trouble. We need to confirm with an ultrasound, and it looks like a bunch of clusters, like a grape cluster in the uterus. That's what you'll see when you do that ultrasound. They go in and they evacuate the contents of the uterus as thoroughly as they can. We're going to draw HCG levels and watch the HCG levels drastically decrease, and we'll wait till they get down to 0. And then monthly, we are going to get the HCG level and keep it. We want to make sure it stays down at 0. Because if it starts increasing, guess what? All those cells are regenerating and coming back like the cancer that it might end up being. All right? So A, you aren't having a baby like you want. B, there's a 20% chance that you are going to progress towards cancer. And C, just to put an icing on the top of it all, you can't get pregnant for at least another year while we monitor to make sure you're not getting cancer. Ow, 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 right?
Can I ask a question? So is there a sperm and egg involved in the beginning then?
Yeah.
And it creates this?
Mm-hmm. But for some reason, and I'm not sure why, it just does not generate into a genetically recognizable embryo. So that's a complete mole. A partial mole is that there is a fertilized egg that starts the process. There could be some genetic material in the contents that are evacuated from the uterus, but it's still not compatible with life. It's not an actual embryo that's developing normally. It's still those grape-like clusters. 6% of these will progress to choriocarcinoma. Again, very closely monitored for the year. Sometimes docs will say 6 months. The more conservative doctors will hold off for a whole year. They want the patient to hold off for the whole year. That's what it looks like upon ultrasound. This is a molar pregnancy that has actually invaded the wall and perforated the uterus, causing major bleeding issues for that patient. This patient's gonna feel pretty lousy, as I mentioned before. Excessive nausea and vomiting, excessive size of the uterus and HCG levels. The bleeding will be dark prune juice-like bleeding if it's coming from the vagina. It might be bright red bleeding if it's like in the abdomen. Yeah, pretty nasty. You have to do that ultrasound. That's the only way to truly diagnose the problem.
Is it possible for somebody with these to get pregnant again eventually?
Yeah,
and have a
absolutely, absolutely. We just want to make sure those cells, those abnormal cells do not return, or that we got them all. You know, that's kind of the, I mean, for anyone who has had cancer, that's kind of our hope with whatever procedure you have to get rid of it, right? It's to get it all, hope to got it all, so that nothing starts growing back. Same deal, really.
So
All right.
once you remove this potential cancer
Mhm.
thing, the HCG levels will drop?
They will drop, yep. The problem is, like cancer, it might grow back. So that's why we have to monitor. We're gonna monitor very closely to make sure that the HCG levels don't start rising again.
Does this sometimes end with hysterectomy?
Good, especially if it has invaded through the wall of the uterus. That could lead to insult number 4, or actually, I guess it takes care of insult number 3. You've completely lost your ability to ever have a baby following that, yeah. Then we move on to the 3rd trimester, and those are placenta issues. Placenta previa is an issue we often now know about ahead of time because we're doing more ultrasounds. Placenta previa is when the placenta is covering the cervix. So when the cervix starts opening, placenta is gonna start bleeding, not fall. All those blood, that richly supplied life force, the wrong side is it's attached. It's gonna bust open and break open the dam of a lot of bright red bleeding. All right. Sometimes, like I said, we know in advance that this is happening. We know that this can happen. So this is a very high risk pregnancy. Pelvic rest, complete pelvic rest, which means nothing in that vagina. All right. They're going to probably take by C-section earlier than this is a medical indication for a scheduled C-section before 39 weeks. Because the last thing we want is that cervix to start losing its integrity, thinning out, and starting to open up, because that just opens the wrong end of a placenta. All right, lots of bright red bleeding, not fun. We had a patient at Manchester Hospital this last year who had a complete placenta previa. She was brought in, I don't know how many weeks she was. She wanted to wait as long as she could, reasonably. She was put on complete, strict bed rest in the room right across the hall from the OR. And monitored frequently, but basically she was there for when she started causing trouble, and she indeed caused trouble, and got, you know, shipped across the hall to the C-section room. And every mom and baby ended up being fine, but she lost a fair amount of blood in that very short period of time. And that's in the controlled circumstances. So that's how serious it can be. So it's a painless, bright red bleeding. That's the key presentation for this problem. There are a couple of different classifications of placenta previa. The first one is complete or total previa, and that is when the placenta is covering the entire cervix. All right, that placenta is not going anywhere other than out the wrong end. An incomplete or partial is when it's just the edge of the just the edge of the placenta is covering the cervix. All right. So it's not as extreme. A marginal or low-lying placenta previa is, it could just be touching or slightly overlapping the cervix, or just right up against the cervix. And as the uterus grows, oftentimes those actually resolve, because the uterus grows and kind of pulls the uterine wall, that part of the uterine wall, away from the cervix, and the placenta gets out of the way. All right?
You said it was complete pelvic rest?
Oh, yeah.
Yeah.
Nothing going in there, causing trouble. Enough trouble caused
For how long?
till the end of the pregnancy.
Oh, the whole time?
Absolutely. Because this is a ticking time bomb. This is you don't want anything causing any sort of disruption. All right? These are the pictures.
Does that mean, does that mean that, there's like working implications where they can't work?
Oh, absolutely. Early in the pregnancy, it depends on when they find out about it, to be honest with you.
Like, once they find it, like, does it say, like, you have to be out for the rest of your pregnancy?
No, not necessarily. It depends on how they find it. If they're finding it because she was bleeding, then we worry a little bit more. If they find it on routine ultrasound, there's pelvic rest. There's might be modified duties depending on what the woman does for work, possibly. It'll be individual. It's not necessarily bed rest at early stage of the pregnancy. It is later in the pregnancy, though. They get very strict, because later in the pregnancy is when the cervix starts thinning and opening and losing its integrity.
Is this specific to one trimester, like only the first trimester, or can it happen?
It's when at the beginning of the pregnancy, when the placenta implants into the uterine wall.
Oh, okay.
It's sealed its fate at that point.
Got it.
The only time it can change is when it's a low-lying placenta previa that pulls away from the cervix.
Okay.
But you're never going to, I guess never say never,
Yeah.
but you're never going to see one that was away from the cervix go down into the cervix.
Okay.
The only way it's a third trimester bleeding issue, because that's when we're going to usually see trouble with the placenta previa, okay, with bleeding. Painless bright red bleeding, definitely, okay. Patient comes into my labor and delivery suite having vaginal bleeding. If I don't have an ultrasound, official ultrasound, specifically stating where the location of that placenta is, I am not doing a vaginal exam. Because it's not my hand, it's not my fingers that are going to poke a hole in that placenta. Okay? And that's not just my personal opinion and philosophy. That's the deal. No vaginal exams for unexplained bright red vaginal bleeding in the third trimester without confirmation of location of placenta. Okay? Definitely, if we do have bleeding, we have to make sure everyone's okay. Is mom losing too much blood? Has the baby lost too much blood? Where are we in terms of health of both patients? And then we have the abruptio placenta, or placenta abruption. This is a nasty, nasty thing. This is when the placenta, it doesn't matter where it's attached, to be honest with you. The issue is that it's no longer attached. So the placenta has decided to exit the building long before the baby has decided to exit the building. So I say that in jest. The placenta tears away from the uterine wall. It can be a partial tear. It can be a complete tear. What happens is the uterus, the difference is, this is intense, sudden intense onset of pain, okay? And the bleeding can be a dark blood if there's any bleeding coming out at all. So sudden onset, intense pain. It's usually the uterine wall usually gets like really, really tense, and you might just feel like one long contraction, and that placenta is just getting blown off the wall of the uterus. Again, there's there's different kinds. I will say that this is a significant cause of both maternal and infant or fetal morbidity and mortality. All right? It can be, again, there's varying degrees of it. It can be, depending on, let me just give you an example. A horse kicks you in the belly, and you're 36 weeks pregnant. Trauma to the abdomen can cause this to happen. But you're out at the farm all by yourself. You were just feeding it. You were just doing your barn chores. And the horse, it was normally gentle, for some reason gets spooked, kicks you in the belly. So now you're out in the barn, there's nobody home. You're in a sudden, intense pain with nobody around to help you. There's a good chance that both you and your baby are going to die. Because we have a massive amount of bleeding that will not support either life very well for very long. Car accidents. We see that pretty frequently. Full-term pregnant woman gets into a car accident, whether it's the seat belt or the impact of the steering wheel. She may have no outwardly bodily injuries, but her baby may not make it. There is abdominal trauma in terms of abuse. Domestic violence increases during pregnancy. So it could be somebody forcefully assaulting your abdomen. And it could be a blood pressure issue or, say, cocaine issue or something that increases your blood pressure or the vasospasms or both, and it's just that blood is pulsating through the placenta at such force that it blows it off the wall of the uterus. So there's some medical reasons also why it would happen. But where it happens and how much time passes between when it happens and when you get care will depend on whether you survive this tragedy. I think I did a good job talking about all those things, didn't I?
Also, previous incidents can cause,
Yeah.
like if you've had.
So if you're still doing cocaine,
No.
you still have hypertension, you may have some sort of, we don't know, maybe there's an abnormality in the uterine lining that prevents the implantation of a placenta securely. I don't know. Or maybe you're still having domestic violence issues, or you just don't drive well and you got into another car accident. But yes,
So that's like the repetitive of those risk factors, not like if you had one 5 years ago from a car accident and you're pregnant again.
correct.
Got it.
However, maybe it is scarring of the abdomen that could lead to another problem. So yeah. So sudden onset intense pain versus painless bright red bleeding. See the difference between the two? They might present kind of similar. You see a bunch of bleeding, and it's a placenta issue. I remember a ER doc wanting to keep a full-term pregnant patient who was actively and heavily bleeding out of her vagina. He wanted to keep the patient in the emergency room. I want to stop the bleeding. I said, well, then bring the patient up to our C-section room. Because that's the only way we're going to stop this bleeding, is because you just didn't get it. Now, this is the same doctor who would send a 17-week pregnant person with a head laceration to OB. It's the full-term pregnant patient with active, heavy vaginal bleeding that you need to send to OB. And nothing you do down here in the emergency room is going to take care of the problem. And I believe I used words similar to that to get my point across.
You're getting to your 45 mark. 45.
Yeah, thank you very much. How much more do we have?
You're at 27 out of 45.
No, not time-wise.
Wow, okay.
A lot of pages.
We're at 27 out of 50.
All right, let's fit. Sorry, did I say that out loud?
27.
So the problem with this is we need to support mom and baby if baby survives, okay? We're gonna find out what's going on and hopefully address the itch support in terms of blood volume, IV fluids, get that baby out. There's some pictures. This is the picture of when you could have a partial where it actually is sealed off on both ends. You can still have that sudden, intense pain, a rigid abdomen or uterus, but you don't see any bleeding. It's because the bleeding's happening behind the placenta, and eventually it might build up so much that it, boom, will eventually blow, or it will seal itself off and tamponade itself, okay? We don't know. And then this is, a problem. These are just some pictures of the different kinds that you might have. These are the difference between these two third trimester bleeding issues. Clearly, I find these differences, telling the difference between the two, important enough that I think I've talked about it and given you several slides on how to differentiate. And then we will take a small break.